Hello, and thank you to the Learning Health Systems Rehabilitation Network for giving me the opportunity to share how looking at pain and rehabilitation research through the lens of inclusivity and anti-racism could inform study design choices and thus enhance the generalizability of the findings to racialized and medically underserved populations. I would first like to acknowledge that I am presenting on the indigenous land once occupied by the Lenape people. First, I'll start with some acknowledgements and disclosures. And I will start by introducing the Anti-Racism Coalition in Pain Research, or Action PR, which we informally call ourselves the Pain Justice League. So about 2 years ago, the highlighted individuals and I saw a need for interrogating how racism and anti-racism were present in pain research. And so with the help of these wonderful individuals, we formed the Anti-Racism Coalition in Pain Research, or Action PR, which is a foundational collaboration toward anti-racism in the field of pain. We are from different disciplines like psychology, neuroscience, physical therapy, and public health, spanning the globe, with expertise in pain inequities, clinical pain research, basic science, and translational research. I'm truly honored to represent our Action PR group in this forum and share what we've been doing and what still needs to be done. I have no financial disclosures or conflicts of interest for this work. So I do want to start to contextualize the conversation reading this book from the Heather McGhee's book, The Sum of Us. The story of this country's rise from a starving colony to a world superpower is one that can't be told without the central character of race, specifically the creation of a racial hierarchy to justify the theft of indigenous land and the enslavement of African and indigenous people. In the 17th century, influential Europeans were starting to create taxonomies of human beings based on skin color, religion, culture, and geography, aiming not just to differentiate, but to rank humanity in terms of inherent worth. This hierarchy, backed by pseudoscientists, explorers, and even clergy, gave Europeans permission to exploit and enslave. So, from the United States' colonial beginnings, progress for those considered white did come directly at the expense of people considered non-white. So although one of the fundamental values of scientific praxis is objectivity, subjectivity is embedded in the framing of our research questions, study design choices, data collection methods, and how scientific findings are interpreted and disseminated. So to facilitate the necessary shift toward inclusivity and advocacy in research, these are some of the tenets that I encourage you to reflect on in your research, while simultaneously actively shifting language that blames individuals to holding systems of oppression accountable for continued disparities and inequities and in health outcomes. So to be reflective to me means analyzing my own positionality in the research enterprise and in the classroom, and to develop and cultivate cultural humility in these spaces. This also means actively dismantling the dominant narratives about deficit models of health, views of healthy and normalcy, and static notions of health, culture, and language. To be intersectional, is to acknowledge multiple identity experiences and oppression, and to examine and dismantle the ways in which policies and health practices perpetuate harm in the context of multiple identities. To be inclusive to me means the inclusion and validation of patient perspectives and to be community engaged. So this means to incorporate and validate cultural histories and values, multiple perspectives in our research and scholarship, and to translate these findings into strategies for improving health literacy and fostering patient empowerment. And to be justice-centered means raising awareness of health inequities and incorporating health evidence-based calls to action. And advocacy is also more meaningful to our patients in the research space. So this table represents one of the adaptations of the Minority Health and Health Disparities Research Framework. It's a multidimensional model that outlines a vast array of health determinants or indicators that are socioculturally relevant to this examination of health disparities and the health of medically underserved population. This model is meant to illustrate how health outcomes can span from individual levels to systemic levels across the lifespan. And this is not an exhaustive list of factors, nor is it intended to be. The framework displayed here is an adaptation of the original framework to make it culturally specific and relevant to Puerto Rican populations. And so frameworks such as this allows for researchers, clinicians, and communities to assess progress, to identify gaps in research and clinical care, to develop meaningful and sustainable partnerships with people with lived experiences with health conditions, and to identify research funding priorities. So a lot of what I'm going to talk about today is drawn from the series that we published on Confronting Racism and All Forms of Pain Research. I'm going to focus heavily on some principles that we outlined in the second paper in this series, but I highly encourage you to read the first paper in the series, which contextualizes the Reframe study designs and strategies for community engaged research in the second and third papers. So my primary goals for today are to highlight some common study design factors with some reframing using inclusive anti-racist research frameworks, and to talk about some considerations with respect to the culture of research itself, with the caveat that the study design factors and suggested reframes should not be seen as rigid and all-encompassing rules, or that employing certain study designs is prohibitive. The study design reframes were designed to serve as starting points for researchers to consider and for identifying areas of growth. So the first study design factor I'm going to discuss is a dominant biomedical narrative. Metanarrative, excuse me. So what is a metanarrative? Metanarratives are theories or interpretation of events or circumstances that shape people's beliefs. So one scientific metanarrative that you may have heard of is this idea that sickle cell disease only affects Black populations. And so what is the potential relevance to rehabilitation research? Well, a dominant biomedical narrative in this context might foster a greater focus on mechanistic research, and it often minimizes or mid-psychosocial factors that contribute to the biology or psychology, and are often informed by scientific publications, conference proceedings, and providers' interpretation of patient cases. So what could a potential biomedical narrative look like in rehabilitation research? It could be more emphasis on the movement impairment rather than on the person with the mobility issue. It could also mean that biological measures are considered more scientifically rigorous and highly valued over measures and methods that interrogate sociocultural and environmental influences on health. And it could manifest as more emphasis on proving an intervention works instead of evaluating the sociocultural and policy factors that can affect its efficacy, effectiveness, or uptake. So why could a dominant biomedical meta-narrative be problematic? Well, it could drive research questions and study design choices that may uphold or worsen rehabilitation disparities. And more often than not, it views innate biological factors and individual choice as primary mechanisms for health disparities. And so a sample research, overarching research question that we can use to illustrate this point in a rehabilitation research context is a pain researcher or a researcher wants to know if a 12-week resistance training program improves function in adults with NEOA. So if we had a potential question that could use a dominant biomedical meta-narrative could be, does a 12-week resistance training program increase quadriceps activation during the loading response phase of gait? And some common study designs that may be used to answer this question could be randomized controlled clinical trials or randomized clinical trials, cross-sectional studies, or cohort studies. And so this figure illustrates a roadmap of key study design features that I've adapted from Dr. Catherine Lang's wonderful talk at the MR3 conference about clinical trial design. And so the research question that employs a dominant biomedical narrative could potentially focus on impairments at the molecular or tissue level or at the movement level in vivo. When thinking about the target population using a dominant biomedical narrative, the inclusion and exclusion criteria for this question would likely focus on meeting the diagnostic criteria for moderate to severe knee osteoarthritis and or having a certain level of function in order to be included in the study. When thinking about the intervention itself on quad activation, or the impact of the intervention on quadriceps activation, researchers might focus heavily on how the intervention is delivered, methods to determine the mechanism of action, and the integrity of the randomization and blinding process. When selecting outcome measures for this particular question, they're often impairment-based. And so some examples of outcomes that could be measured with a question like this would be measuring motor evoked potentials, peak knee extension moment during stance, or gait speed. And finally, the statistics selected to analyze these outcomes may focus heavily on differences pre and post intervention, differences between groups, and or looking at predictors of the change of one of the impairment-based outcomes using regression analysis. So an inclusive and anti-racist reframe of this factor would be to employ study designs that better reflect a biopsychosocial narrative. And this would consider how interactions between biological, psychological, and social factors contribute to pain and rehabilitation outcomes. And so social factors create conditions by which patients access to proper education and follow up with therapeutic exercise outcomes, which inequitably affects racialized groups. Thus, social indicators of health are considered upstream causes of some of these health disparities and inequities in this context. Furthermore, there are cultural considerations that influence the participation and community uptake of any intervention that should be accounted for during the study design phase in collaboration with patients and community members with lived experience with NEOA. With this in mind, a possible reframing of this question could be, do adults with NEOA perceive a meaningful improvement in their activity participation after a 12-week individualized exercise program? When you reframe the question in this way, you potentially expand the study design possibilities, such as when you can still employ randomized controlled clinical trials. You can also include pragmatic, mixed methods or qualitative studies and longitudinal cohort studies, which may yield more information about the context in which the intervention is or is not efficacious or effective, which could definitely enhance the research. And so when you shift the research question from this dominant biomedical narrative, there's also a shift in study design methods and choices and analyses that could enhance the research. So in returning to our study design roadmap, the research question that employs a dominant biopsychosocial meta-narrative could potentially focus on composite measures of psychological and sociocultural factors that influence changes in lower extremity function after the intervention. Some examples of these could include culturally relevant pain assessment, experiences with bias and discrimination, or levels of social support. When thinking about the target population using a dominant biopsychosocial narrative, the inclusion and exclusion criteria for this question would de-emphasize meeting the diagnostic criteria for moderate to severe NEOA in favor of ensuring adequate representation of racialized or marginalized groups that are disproportionately burdened by high impact chronic pain and disability associated with NEOA in different contexts. So when thinking about the efficacy of the intervention using this narrative, meta-narrative, researchers might still focus on how the intervention is delivered, but would also consider how the intervention is received by patients and providers with the goal of implementation in mind. And when selecting outcome measures for this reframe question, a researcher could select primary, secondary, and exploratory outcomes that better reflect patient values. For example, measures of disability, quality of life, patients' views of the change in their pain and function, levels of perceived stress. The statistics selected to analyze these outcomes may focus on differences in the primary and secondary outcomes pre and post intervention, but one could also employ statistics that identify responders versus non-responders. To include psychological and social factors into these regression models, or if employing mixed methods or qualitative research, identifying themes from participant interviews that could help with the interpretation of the findings. So the study design factor that I'll talk about next is something that we all grapple with in our research, which are low numbers of participants from racialized and marginalized groups. And so to begin the discussion of this design factor, this figure is an adaptation of one of many figures related to conceptual frameworks around diversity, equity, inclusion, belonging, and access in business settings. So when applied to the research setting, key questions should be addressed during the study design phase in an effort to ensure better generalizability of the findings. And so diversity addresses who is involved in the research, who is included in the research. And not just the study participants, but the makeup of the research team itself. Equity addresses who needs to be included in the research, but likely isn't, and potential reasons for that. Inclusion asks whether or not the perspectives of those participants who are at the table, participants and researchers, it is understood, valued, and respected. And belonging, questions around belonging and access, meaning they ask these critical questions about whether or not these perspectives are actually integrated into the research in the form of study design, the dissemination, or any other part of it. And do people have access to the information about the study and its findings? So why is census matching problematic? Census matching is often used as a strategy to describe and incorporate sample diversity. The historical context in which the US Census was developed is beyond the scope of this talk, but those who were recognized as slaves were counted as 3/5 of a person, and indigenous individuals were not included in the count at all. And so the flaws in how these populations are represented still linger in terms of gerrymandering of incarcerated or paroled individuals and coding around US citizenship. And so one of the things that becomes problematic is that the dominant group from a region or from a country, the findings often from that group, people assume will generalize to other groups with the same condition. There's also This also masks rapidly changing shifts in demographics in regional and national populations. So there's often a lag in the availability of census data when thinking about these shifts. And great examples of these are shifts from urban or cities to rural or suburban populations. And you just can't really capture that in real time with the census. And finally, there's the groups with the highest disease burden often have the lowest representation in studies of the disease. And so this is a figure from a recent paper from Steinhardt et al., which displays the representation of women versus men, biologically sexed women versus men, in clinical trials of different health conditions compared with the burden of disease within the population. And disease burden is operationalized in this paper as disability adjusted life years, which means years of healthy life lost due to the sequelae of the disease. And so sex representation in clinical trials varied based on the health condition being studied. But interestingly enough, there was a higher representation of biologically sexed women in clinical trials examining musculoskeletal health issues or trauma than the proportion of women with musculoskeletal health issues. And so this highlights the importance of not just using census data as a strategy for promoting diversity in research studies, because it could misrepresent the actual disease burden on the marginalized or underrepresented group. And so an inclusive and anti-racist reframe of this factor could be to just adopt new ideologies and strategies to promote inclusion in research. And so this is a figure from the paper itself that identified 6 key areas or barriers to study sample diversity inclusion, although this is by no means an exhaustive list. So starting with investigative team training, training the research team in best practices for engaging with different patient populations is essential to ensure fidelity and to engage with the study participants appropriately. However, what often happens is that there's limited attention to cultural humility, multicultural competency, or principle of anti-racism. And so this should be embedded in the investigative team training. The research question itself, which is kind of a running theme in this talk, it often doesn't consider in the realm of the research that many of us do, mobility or pain concerns most relevant to marginalized groups, and community stakeholders from marginalized or racialized groups are rarely consulted. And so inclusive and reframe strategy could simply be to include stakeholders early on when developing the research question. Participation criteria, inclusion and exclusion criteria are heavily influenced by systemic racism and other biases. So when we exclude people based on their BMI, cardiovascular health status, or language fluency, this upholds these systemic racist narratives and white hegemony, or thinness, body type. And also biases in exclusion or exclusion rates are often not tracked or addressed when we talk about the participation criteria. The burden on participants is also a problem. So study visit timing is often not flexible, transportation is often not provided, and the in or out of visit window is often too narrow. So to minimize participant burdens, you can simply be more flexible in your visit timing, provide transportation, and make modification to your in or out of visit window. Study materials, whether they be educational materials or addenda to materials that are part of the study, they often lack consideration for literacy levels, or They lack effective translation of study materials into other languages. And in the live Q&A, I can give a anecdote that my colleague used in one of the classes that I co-teach. And so effective translation of the study materials with consideration for language literacy is paramount to being more inclusive. Research advertisements. Community organizations are rarely consulted in the best practices for disseminating key information about research studies via print, social media, or radio ads to racialized and marginalized communities. And so developing authentic partnerships with community members to identify more specific strategies for mitigating these barriers to sample diversity and inclusion will have a universal benefit and greater collective impact on our work. And so to go back to the point of developing procedures for monitoring recruitment bias, this figure is a representation of how information about a study is disseminated among racial groups as defined by the US Census. This data is generated from an in-house R script developed by this esteemed researcher pictured here. And what it shows is that those in a white racialized group have access to more information about clinical studies using a variety of information channels, such as clinical connections, clinicaltrials.gov, and internet ads. People who are raced Black have a similar diversity of information channels, but have less access. And what's also clear from this figure is that other racialized groups have over-reliance on one or two modes of information, which could be evidence of bias in recruitment simply based on how the information about the study is getting out there. And so the third study design factor that I'll talk about sparked a spirited debate among our focus group, but hopefully I can convince you that there are more appropriate strategies to examine the impact of having a racialized or marginalized identity on health. And so a sample research question, a different one from our previous one, is a researcher wants to know if knee pain and function in a racialized Hispanic or Latino adults with knee OA are better or worse than that of white adults. And so a question like this would usually employ a traditional health disparities study design, which is often comprised of either cohort studies, cross-sectional studies, or case control studies, which compare one group or one racialized group in this case to another racialized group on an outcome or mechanism. One racial group versus another, yes. So when thinking about the target population using a traditional disparities health design, or the question itself, it usually focuses on US Census racial group categories. And we'll talk a little bit about the pros and cons of that. When thinking about the target population using this health disparities research design, the inclusion and exclusion criteria for this question would likely focus on sampling those who are raced Hispanic or Latino by the US Census and comparing them with age, sex, and BMI matched white controls. There would also be a collapsing of racialized groups like Asian or Asian American and Pacific Islanders or indigenous populations into the damned and dreaded other category because of low sample sizes for these groups. When thinking about the methods in this traditional health disparities model, researchers tend to focus heavily on the biological or other interpersonal mechanisms of the disparity, with the hypothesized mechanisms often centered around biological differences and or individual choice. When thinking about the outcome measures or selecting outcome measures for this particular question, they're often a combination of impairment-based and function-based outcomes. And some examples of this could be measuring gait speed or looking at general and disease-specific measures of function. The statistics selected to analyze these outcomes often focus heavily on finding group differences and or looking at predictors of change using race as an independent variable or predictor of change in one or more of the impairments-based outcomes using regression modeling, in which race is either used as a covariate or as an independent variable in this model. And so one of the strengths of using a traditional health disparities design is that it can identify inequities in conditions or highlight a disparity or inequity that has not yet been identified. So if there's a rare health condition that in which inequities have not been identified, you can find them there. It also could encourage the inclusion of racialized groups as a body of work accumulates, that there's a systematic exclusion of these groups using this design. And it could also build on existing literature on the topic to allow for the tracking of progress toward health equity in the condition being studied. Well, what are the limitations? So race is a socio-political variable that is complex and lacks specificity. Thus, researchers often don't explain the rationale for using race as to statistically adjust for race, nor do they share the insight into the meaning of this factor in the context of the statistical model, which can lead to inappropriate interpretation of findings. And so the limitations, to build on that, limitations of this model, it asks where but not how. So it identifies that a disparity or inequity exists, but how or why is it there? It often leaves the possibility of misinterpreting differences as being due to biological factors or individual behaviors, rather than to interrogate the impact of multiple systems of oppression. It also limits the inclusion of the perspectives of the groups that are disproportionately burdened by the disease. It often uses race as a proxy for other factors, social and cultural factors that could be measured directly, and you likely lose within group heterogeneity. And so when you are raced Hispanic or Latino in the case of this question, that encompasses a huge range of ethnicities and nationalities. And if you're looking at a comparison to other groups, you lose that within group heterogeneity or the ability to examine that. And so the selection of the control group and using white racial identity as a control group can be problematic, because it's rooted in white supremacy and cultural norms that state that being part of a group that's raced white is good, and often assumes good outcomes or overall good health, when that may not indeed be the case. It also leaves a possibility of for that misinterpretation of differences being due to biological factors or individual behaviors, rather than due to systems of oppression. How we define the healthy control group is also rooted in these social cultural norms that I just described, but it doesn't consider the influence of other health conditions and how that could impact the variability of that group when comparing to the target population of interest. And it also feeds into dominant meta-narratives about deficit models of health, for example, characterizing movement, different types of movement as being normal or abnormal. And so this dominant meta-narrative about deficit models of healthy, normalcy, and healthy being normal, and static notions of health, culture, and language. And so as many of us heard at the recent MR3 conference, the selection of control interventions is also a key element of designing clinical trials. This question is not a clinical trial, but for questions that do employ clinical trial designs that evaluate the efficacy and effectiveness of the interventions. And so the more standardized the control intervention, the higher the internal validity and less potential for bias in the study. And so when I was thinking about this through an inclusive and anti-racist study design lens, I would argue that asking patients how they self-manage could be a key element that could inform how the control intervention is designed and implemented. And although it could introduce more variability in the results, it would serve to evaluate the efficacy of the intervention in a culturally relevant patient-specific context, rather than to prove that the intervention being studied works better than a different intervention or usual care, since there are often inequities in how usual care is delivered to marginalized groups. And so an inclusive and anti-racist reframe of this factor would be to measure the lived experiences pertinent to racialized or marginalized individuals and interpreting the findings in this context. So we could reframe this research question by asking, a researcher wants to know if acculturative stress is associated with pain and function in racialized Hispanic, Latino, XA adults with NEOA. And when the question is framed in this way, there's an inherent rejection of the idea that racialized disparities arise simply from biological differences or stereotype group traits. And so this opens up the design possibilities considerably. And so you can still examine the variability across groups. So if you wanted to look at or confirm the presence of a disparity, you can still do that, but instead prioritizing racialized groups' inclusion and questions that are most relevant to that group. Or you can simply examine the variability among the racialized group of interest. And so that the study design possibilities that open up when you think about this reframe in this way are doing longitudinal observational cohort studies, implementation studies in the form of pragmatic trials or adaptive trials or other implementation study designs, randomized controlled clinical trials, or case control studies. And so there are measures, in addition to using qualitative methods to simply ask about this, there are tools out there, and there's a pretty comprehensive list of these tools in the second paper, where you can actually measure the lived experiences of people, and with some examples. So I won't read all of these to you, but if you wanted to ask about immigration, the lived experience of immigration to the US, you can simply ask about place of birth, immigration status, if a person is comfortable with sharing that, years living in the US. If you wanted to interrogate the role of religiosity, or how a person incorporates their religious beliefs in their lives and their management of pain or their movement problem or issues, you can use these surveys such as these to interrogate that. You can also look directly, the sample question interrogates acculturative stress. So you can include this measure as an outcome in the study, in addition to lived experiences with racism, related stress, or historical trauma. If you wanted to include the influences of the physical or built environment and policy influences, you can look at the GI statistic, the US Census Bureau current population survey, look at the influences of voter suppression or muted political participation using district map, or use geographic coding and information systems. And so the research question that employs this reframed inclusive anti-racist study design, which now focuses on these factors that are relevant to a target population as potential mechanisms of disparity in NEOA pain based on function. And some of these measures could include self-reported measures of acculturative or race-related stress or levels of social and emotional support. When thinking about the target population using a reframed, inclusive, and anti-racist research design, the inclusion and exclusion criteria for this question would likely focus on sampling those who are raced Hispanic or Latino by the US Census. And because this research question focuses on the lived experiences of this racialized group with NEOA, a cohort or cross-sectional study of just this group would be appropriate. And so this would allow for the examination of within group heterogeneity of the outcomes and also the potential intersections with other identities. When thinking about the methods in a reframed study design, the researchers can expand their characterization of potential intra and interpersonal factors that could predict the pain and function in this racialized group. When selecting outcome measures for this reframed question, a researcher could still select primary, secondary, exploratory outcomes that reflect these values, much like we did earlier. And some of these examples are more patient-specific and culturally relevant to the question of the mechanism of a health disparity. And finally, when thinking about analyses in the context of this reframe, a researcher could use the advances in statistical modeling to examine the psychological and social factors that predict or mediate relationships between pain and other variables. And they could also report subgroup differences in these primary outcomes, even if the differences are not significant, which could extract information about the role of intersectional identities potentially. And so the last study design factor I'll discuss is preclinical research in biomechanics rarely model the effects of social factors on movement and pain. And I know I just told you the perils of a dominant biomedical meta-narrative, but in some cases, a research question may call for that. And so when we talk about the translational research spectrum, we often talk about the T0 through T4 translational path from identifying targets and biomarkers of disease through implementing them and using them to detect disease, the progression of disease or improvement of it at the population level. And so some concerns that arise with this is that frequent systemic and interpersonal experiences with racism, ableism, social oppression, and other political marginalization, forms of political marginalization or exclusion are chronically stressful over a lifetime. And so the physiological manifestations of these factors have been documented in other fields. So the lack of consideration for the influence of these social factors on biological and psychological processes increases the risk of identifying pain or other disease biomarkers that may not apply to socially and politically oppressed groups. Moreover, race is often conflated with genetic ancestry and could uphold false narratives of racial disparities arising from biological as opposed to sociological factors. And so when disease biomarkers are discovered, it may not generalize to people with chronic physiological stress, but it often overlooks possible protective factors for marginalized groups. The analgesic medical device or the exercise intervention developed may not help marginalized populations and may not account for the impact of intersectional identities, and thus could worsen inequities. And so a possible mechanistic research question, exploratory question, could be Does a vitamin supplement slow the osteoclastic activity of subchondral bone? Using possible studies designs that combine preclinical studies using functional assays and behavioral assays that should mimic, designed to mimic some human behavior, and employing forward and back translational studies that employ protein assays, omics, and clinical outcomes. And an accompanying clinical or translational research question could be, does osteoclastic activity of subchondral bone correlate well with self-reported pain? And so an inclusive and anti-racist reframe of this design factor is to develop translational research models that account for the impact of racism-related stress on physiological processes. And so a reframing of this translational research spectrum could significantly enhance the effectiveness and uptake of these rehabilitative interventions. So first, researchers could conceptualize the translational research spectrum as bidirectional, meaning that if an intervention is not deemed safe or efficacious in the early phases of evaluation, or has not led to the community uptake needed to evaluate its effectiveness, researchers can retest and reevaluate the intervention at any point. And more importantly, the intended use of biospecimens, images, study aims, and risks and benefits of participation need to be explicitly stated and translated in the language, in many languages, to build and maintain trust in the biomedical research process. And so there are many ways to have an inclusive and reimagined framework of the spectrum. But as illustrated here, the perspectives and values of all of the patients with lived experiences with the condition should be included at all phases of the research process. And so preclinical and animal studies can incorporate behavioral assays and models that model aspects of racism-related stress, such as social isolation and exclusion or environmental deprivation. And during the early phases, like phase 1 and phase 2 clinical trials, building collaborations between basic scientists, clinical researchers, and racialized and marginalized patient advocates is also key, plus the early inclusion of underrepresented groups in the safety and efficacy studies is key. And designing phase 2 and 3 clinical trials with the goal of generalizability and implementation in mind to racialized and marginalized groups is important. And a key component of this would be to include social indicators of health as clinical endpoints. And so to reframe this design, it's still rooted in a dominant biomedical narrative, but you can incorporate a lot of the principles that we've talked about in previous slides in the study design to make the research more inclusive and generalizable to racialized and marginalized populations. And finally, I'm going to talk a little bit about considerations or things to think about when we talk about research culture in and of itself. And so we've heard of social indicators or social determinants of health in the literature and in clinical practice, but a better integration of social and biopsychological measures in research studies, pain and rehabilitation are key, and a higher valuation of looking at studies that include these social indicators or determinants is needed by funders, peer reviewers, and the scientific community overall. And finally, these researchers, Dr. Chaudhry and Verhey, speak specifically towards creating an inclusive and anti-racist lab. And so they came up with 10 of the best ways that they could think of to do that, which I won't read all of these for the sake of time, but it includes even discussing racism and anti-racism, addressing it in the lab and clinic, collaborating with colleagues from underrepresented groups, advocating for racially neurodiverse and people with disabilities in leadership, supporting efforts to organize around health equity and social justice, and holding powerful people accountable without the expectation of gratitude. So I want to thank you all for listening and acknowledge those who had individual roles in the think tank that informed a lot of this work that I talked about today. Thank you.